In 1969, 80 inmates of Mount Carmel Hospital in New York lingered in stuporous states. Survivors of the sleeping sickness epidemic known as encephalitis lethargica or von Economo's disease, they were neither dead nor alive. Distressed by their condition, a young neurologist desperately looked for ways to revive them from their trance-like states. With few options left, he conceived a 90-day trial of L-Dopa to see if it would waken his patients up. And what happened was nothing short of a miracle. The young neurologist described what he observed as the quickening of patients who had long been regarded themselves as effectively dead. He further described how they emerged from the almost cadaveric states where they had been frozen and hidden for decades to become individuals in all their vitality and richness. The neurologist was fascinated by how these 80 patients erupted into life and referred to this as an explosive awakening. The neurologist was Oliver Sacks, and his book narrating his experience is titled Awakenings, a classic which was translated to the screen with the great Robin Williams playing the heroic author. Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast titled Quickening, Kickstarting the Parkinson's Brain. In the previous episodes on this subject, we covered the clinical features and pathology of the disease. Here, we will continue our exploration by reviewing the history and complexity of its treatments. L-Dopa is at the heart of the treatment of Parkinson's disease, and it is a drug whose backstory is as fascinating as that of the 80 patients it resurrected at Mount Carmel Hospital. Indeed, it is this history that inspired Oliver Sacks to deploy L-Dopa in his patients. The story of L-Dopa starts with the history of its parent molecule, dopamine. In their book on dopamine titled The Molecule of More, Daniel Lieberman and Michael Long attributed the discovery of this important transmitter in the brain to a researcher called Kathleen Montague, and she was working in a laboratory near London in 1957. 1957 was also when Swedish researcher Arvid Carlsson first demonstrated that dopamine was a neurotransmitter in the brain, and this was critical work that earned him the Nobel Prize in 2000. Carlsson went on to show that dopamine was heavily concentrated in the basal ganglia, that is the part of the brain whose function, when impaired, results in Parkinson's disease. Experimenting on rabbits, Carlsson proceeded to show that he could deplete the dopamine content of the brains of his rabbits by giving them the drug called resuscitate, and this caused the rabbits to become very sleepy. Carlsson did not stop there. Rather, he went on to deliver the coup de grace. Carlsson, who had earlier shown that L-Dopa is converted in the brain to dopamine, decided to inject his somnolent rabbits with L-Dopa to see whether it will correct the dopamine deficiency he himself had induced. Describing this in his book titled Brainstorms, John Palfreyman wrote that almost magically the rabbits awakened, became alert, and started to move normally. Wait a minute, you might, however, say. Why didn't Carlsson just administer dopamine to his rabbits rather than going roundabout and giving them L-Dopa? Well, the simple answer is that dopamine in the circulation is unable to cross the unforgiving blood-brain barrier, whereas L-Dopa could snuggle in. Based on his findings in rabbits, Carlsson went on to propose the elegant theory that human Parkinson's disease is the result of dopamine deficiency in the brain. But as we all know, rabbits are not humans. Carlsson's hypothesis needed confirmation in human beings. And the proof came from Austrian researcher Oleh Hornykiewicz and his colleague Herbert Irving, who demonstrated with autopsy studies that relevant parts of the brains of people with Parkinson's disease contained virtually no dopamine. Taking his hypothesis forward, Hornykiewicz and Walter Berkmeyer demonstrated that low dose of L-Dopa in 20 people with advanced Parkinson's disease had a beneficial, although limited, effect. It was not until 1967 that the full potential of L-Dopa was unleashed by neurologist George Cotzias, who used it at much, much higher doses. Cotzias also combined L-Dopa with carbidopa, a molecule that blocks the enzyme that breaks down L-Dopa in circulation, thereby enabling enough L-Dopa to enter the brain and be converted to dopamine. We have now come full circle to why Oliver Sacks considered using L-Dopa in his patients with encephalitis lethargica. These are patients whose clinical manifestations were very similar to those of Parkinson's disease. But Oliver Sacks' contributions to our understanding of L-Dopa went far beyond the miraculous recovery of his patients. Sacks did the unthinkable. He showed that L-Dopa had an evil side that the medical establishment was not aware of or did not want to acknowledge. And this devilish side of L-Dopa has since turned out to be the Achilles heel of using it in treating people with Parkinson's disease. Sacks reported that all his patients who he treated with L-Dopa sooner or later developed complex, sometimes bizarre and unpredictable states. The adverse effects that Sacks observed included abnormal movements, irregular breathing, attacks of respiratory crisis, growling attacks, and intense repetition of words and phrases which neurologists call parlylalia. And this rather harrowing list has only gotten longer over time to include such adverse effects as confusion, depression, and psychosis. Another curious dimension of the adverse effects of L-Dopa, highlighted by Lieberman and Long, are unrestrained pleasure-seeking activities. These hedonistic pursuits range from pathological gambling and compulsive shopping to hypersexuality. According to Lieberman and Long, the reason for this is simple. For them, dopamine is the anticipation molecule which makes us, I'm quoting them here, want things with a passion and to want it right now. Curiously, these indulgent side effects are more evident in a group of Parkinson's disease medications called dopamine agonists. These are molecules that mimic the effects of dopamine at its receptor. To bypass the nasty side effects of L-Dopa, neuroscience had to become creative in developing smart formulations, and these include controlled release and dispersible forms, and also forms that are administered by subcutaneous injections and more recently by inhalation. But perhaps the most disheartening downside of the use of L-Dopa is when it eventually and almost inevitably runs out of steam and no longer makes any dent in the symptoms of Parkinson's disease. To enhance the efficacy of L-Dopa and to minimize its side effects, neurologists have become imaginative in coming up with treatments to assist or take over from L-Dopa. And these strategies include using dopamine agonist, which we've referred to, using drugs called the monoamine oxidase inhibitors and the COMT inhibitors and apomorphine. With all these players in the Parkinson's disease field, one can imagine how complex and complicated things can become. Well, we don't actually need to imagine it. We can take it from someone who has experienced it all. The long-term tumultuous course of the treatment of Parkinson's disease with several medications is graphically portrayed by Veronica Lees in her illness memoir titled The Art of Falling Gracefully. By the time Lise saw a neurologist, she had already developed typical features of Parkinson's disease, and this was a disorder that her own father had suffered from. Her neurologist requested a dopamine transporter scan, also called a DAT scan, which showed that she had already lost 90% of her dopamine-producing cells in the brain. The first treatment she tried for the tremors bedeviling her was trihexyphenidyl, but she said, about a year after taking medication, I began to ache all over when I did anything, and I was incredibly stiff. She then went on to Sinemet, a formulation that contained L-Dopa. She said this did the trick, but a few years later she said, my tablets no longer kept my symptoms under control. At that point, she was prescribed an additional tablet, the dopamine agonist called ropinirole. But after a few months on this, her hands began to swell. This is a well-known side effect of dopamine agonist. To prevent this, she was started on the ropinirole patches. Lise, however, said the trouble was they would not stay on me. They floated off in the shower, in the bath, and in the hydrotherapy pool. After ropinirole was withdrawn, Lise was put on beta blockers for her severe tremors. But, expectedly, she said these made me so unwell, my nurse told me to stop them. She was then put on half Sinemet, which helped her with overnight stiffness, but it also caused abnormal limb and facial movements called dyskinesias. To counter these, Lise was prescribed amantadine. This is a medicine that was initially developed as an antiviral agent, but for some reason found its way into neurology as an effective treatment for dyskinesias. But not for Lise. She said, within an hour of taking my first tablet, I developed full-blown cystitis-like symptoms, and an hour later became incontinent. Lise was then prescribed opicapone, which she said was supposed to concentrate the dopamine in one place in the brain rather than let it wander all over it. By now we can guess the effect. When she took opicapone, she said, I threw up on day 3, and the vomiting was not prevented by taking an antiemetic. Apomorphine was the next medication that was considered for Lise, and this was to stop her from freezing and falling over, in her words. However, she violently threw up just minutes after it was administered. At the time of writing, Lise was being considered for deep brain stimulation, also called DBS. DBS is the culmination of an exciting history of the evolution of the surgical treatments of Parkinson's disease. Before 1952, the only surgical treatment available for Parkinson's disease was called a pedunculotomy. This was an operation that involved cutting a fiber bundle in the midbrain, and whose outcome was not necessarily satisfactory. It was whilst New York neurosurgeon Irving Cooper was performing a pedunculotomy in 1952 that he serendipitously made an advance in the surgical treatment of Parkinson's disease. Cooper was presumably proceeding cautiously when his hand accidentally slipped and he mistakenly severed an artery which supplies the basal ganglia. Yes, that playpen of Parkinson's disease. Shaken but perhaps not stirred, Cooper hurriedly ligated the blood vessel and understandably hurriedly abandoned the procedure. But astonishingly, when the patient recovered from his operation, his symptoms, which were tremor and rigidity, had remarkably resolved. This fortuitous turn for the good marked the advent of treating Parkinson's disease by surgically destroying the basal ganglia, an operation called a pallidotomy. And the next stage was doing a thalamotomy, which is surgically destroying the thalamus, an operation that also seemed to help Parkinson's disease. A celebrated beneficiary of Cooper's mistake was Michael J. Fox, the star of the Back to the Future films. In their book titled Reaching Down the Rabbit Hole, Alan Roper and Brian Burrell wrote that Fox was diagnosed with Parkinson's disease at a high point in his career in 1991 and at the very young age of 31 years. When his diagnosis was still a tightly guarded secret, Fox was referred to Alim-Louis, a neurologist, to advise on the treatment of his hand tremor. He was already taking L-Dopa at the time, but the effect was wearing off too quickly to be effective for him. Fox was also on Artane, a tremor-reducing drug, but this was also not helping him. On Ropper's recommendation, Fox went on to have a thalamotomy, secretly of course, and this was in 1998. And the operation did the trick and resolved his embarrassing left hand tremor. The popularity of the surgical treatments of Parkinson's disease, however, declined with the advent of L-Dopa, which is obviously easier to administer. But the realization that L-Dopa caused severe abnormal limb and body movements called dyskinesias led to the resurrection of surgery in the late 1980s. And the resurrectionist in chief, so to say, was Marlon DeLong, who set up a pallidotomy program in 1990 at Emory University. But just as surgery was set to make its comeback, a new technology stopped it in its track. And yes, the great disruptor was deep brain stimulation. And believe it or not, the emergence of DBS was the result of another serendipitous event in the operating room. The story behind the introduction of DBS goes back to 1987 when neurosurgeon Alim-Louis Benabid was carrying out a thalamotomy operation at the Joseph Fourier University in France. Just as Benabid was about to create a lesion in the thalamus by stimulating the structure at a frequency of 10 to 15 hertz, he had a brainwave. Why not stimulate the thalamus at a much higher frequency of 130 hertz, he asked himself. And so he did. He just had to know, didn't he? And to his pleasant surprise, the patient's tremor resolved. There is, however, a less conventional story of the origin of DBS, which I will explore in a future podcast with Lone Frank, the author of the book titled The Pleasure Shock. But for now, what we want to know is, what is it like to undergo DBS? Let's learn about this from Brian Miles, who wrote about his lived experience of undergoing the procedure in his memoir titled Parkinson's Disease and Deep Brain Stimulation. Miles was diagnosed with Parkinson's disease when he was 56 years old and at the peak of his career as a maritime lawyer, and on a day he said his world changed forever. Beginning unusually with back pain, Miles went on to develop marked forward and sideways curvatures of his spine called camptocormia and scoliosis respectively. He also developed a tendency to lean to the side called the Pisa syndrome. What else? It was only after these symptoms that he manifested the typical features of Parkinson's disease: resting tremor of his hand, muscle stiffness, and slowness of movement. Miles also developed non-motor features of Parkinson's disease, which include an impaired sense of smell, mild cognitive impairment, and REM sleep behavior disorder, physically acting out his dreams in sleep. After botulinum toxin injections failed to improve his back symptoms, and after his surgeons rightly advised him against back surgery, Miles read about DBS on the internet. He consulted a neurologist who confirmed that his spinal curvatures were caused or exacerbated by Parkinson's disease. The neurologist did this by showing that the curvature improved when Miles lied down and also when he was given a large dose of L-Dopa. When his back symptoms persisted on large doses of L-Dopa and the dopamine agonist ropinirole, Miles was put into the DBS pathway. Miles described the procedure in depth, noting that it involved the placement of electrodes in his substantia nigra and connecting the electrodes to a neurostimulator, The neurostimulator, also called an implantable pulse generator or IPG, was then implanted under the skin just below his collarbone. And the outcome for Miles was well worth the inconvenience. Basking in satisfaction, he wrote that DBS has eliminated my tremor, improved my posture, standing taller, improved my movement, not as slow, improved my gait, less shuffling, and decreased lumbar pain and stiffness. It also unmasked his facial expression. To explore the chemical treatments of Parkinson's disease further, I will be speaking to Alim-Louis, author of the book titled Mentored by a Madman, and this will be in the next episode of the podcast. Thank you so much for listening to or watching this podcast, in which we continued our exploration of the important disease that is Parkinson's. Apart from the books I have already cited, I've also relied on a paper titled Arvid Carlsson and the Story of Dopamine by Yeragani, Tansa, Chokka and Baker, published in the Indian Journal of Psychiatry in 2010. If you found this podcast enlightening, you might consider subscribing to NeuroChecklist, my neurology database, and you might also consider exploring my book, Surfing the Brain. And why not subscribe to the podcast, iTunes, Spotify, or YouTube channels to ensure you don't miss the next episode in this theme, which is in conversation with Alim-Louis. I assure you, you don't want to miss it. Join me then. Thank you very much.